Hello everyone. We are going to wait a minute for people to join and then we will start with the webinar. So welcome everyone to today's webinar. Today's topic is the changing landscape of adult GH deficiency. My name is Camelia and I'm project manager of work package 6. I want to say thank you to MTG6 for organizing this webinar. Our chairs today are Nienke, Biermasz and Gudmundur Johannsson. And they will introduce our speakers. I just want to say before that all questions come at the end after the presentations. You can type your questions in the question box or raise your hand, turn your microphone on and ask your question directly. So without further ado, I will give the word to Nienke and Gudmundur to present our speakers today.
Yes, thank you, Camelia. Do we need to wait or can we start?
Well, we can start.
Okay, thank you so much. Yes, welcome everybody. It's an honor to be able to present here today a new webinar, and that's on behalf of main thematic group 5 and 6. Gudmundur Johannsson, MTG 5, and myself from MTG 6 pituitary field thought that it was a good idea to have a moment to think about the new developments in growth hormone deficiency, and especially because we were facing issues with dynamic testing. So there are new opportunities, but there are also others that have left the playing field, and we thought it was a good idea to have a discussion about that. We called the webinar "Changing Landscape of Adult Growth Hormone Deficiency," and it will feature first Professor Johannsson from Aarhus University, then Kevin Yen from the US with a lot of time delay, and then Sharon Criseno from UK, from Birmingham. And then there will be time for question and answers and maybe some case-based discussions. So we aim to have a webinar of 1 hour, but there can be a little bit more time if we need it for the good discussion. So I would like to give the floor to Jens Otto for the first lecture.
Yes. Do you see my slide now?
Yes.
Perfect. Thank you for the kind introduction and invitation to present on growth hormone deficiency in adults. My disclosures. Just to remind you about the fact that growth hormone has been named due to its ability to promote longitudinal growth in children. And if you lack growth hormone deficiency in childhood, you become severely growth retarded. And if you replace with growth hormone, it's highly efficacious, as demonstrated in this case by Maurice Rabin many years ago. And just a very swift crash course in how growth hormone acts. It's a potent anabolic hormone, mainly mediated by growth hormone-induced production of insulin-like growth factor 1, either in the liver or in the peripheral tissues, or both, where IGF-1 mediates protein synthesis in the presence of nutrient abundance, and it promotes the synthesis of lean tissues, including muscle, tendons, collagen tissues, and bone. And it's interesting, if you look at the IGF-1 in the circulation, that if you focus on the age around puberty and after puberty, you see we all have very high IGF-1 levels. It's almost like programmed acromegaly. Growth hormone also has direct effect on substrate metabolism. It's a potent lipolytic hormone, and this effect or action of growth hormone is mainly predominant after long or short-term fasting and during sleep and after exercise. And this results in fatty acids mobilization and fatty acids oxidation, which indirectly is also protein conserving. Indeed, this response was reported also by Rabin, and as a matter of fact, he mainly studied adult subjects, so this was documented in young and elderly adults. Rabin was also the first to suggest that growth hormone could play a role as replacement therapy in the adult, and he treated on a case base a young female school teacher who had severe panhypopituitarism. She received growth hormone and she reported some positive effects, but the supply of growth hormone was very limited in those days. It was from post-mortem pituitary glands. So this scarcity of growth hormone changed in 1986 when biosynthetic growth hormone became available, which allowed us to study growth hormone actions on a broader scale, also in growth hormone, including growth hormone deficiency in adults. The first two papers were reported in '89, and the paper to the left reported data in childhood onset growth hormone deficiency, which was reconfirmed in adulthood, and the patients were treated with growth hormone or placebo in a crossover study, reporting beneficial effects on body composition and other features. The paper to the right was from the UK, and they studied adult onset growth hormone deficient patients with a history of robust history of pituitary disease, mainly after operation for a pituitary tumor, and they reported similar positive effects. I would like to mention a third study, which was a little later, by the Gudmundur group, and they were the first to focus on the impact of growth hormone to reduce visceral or intra-abdominal fat using the CT scan method. They reported an 25% reduction in visceral fat after 6 months of growth hormone replacement therapy in adults with severe growth hormone deficiency due to pituitary diseases. Subsequent to this, a lot of placebo-controlled trials were published and have been published, and one of the early meta-analyses to be reported is this one from 2004, where you can see that there's a robust increase in lean body mass and a reduction in fat mass and also a favorable effect on blood lipid profiles. We do also see a moderate degree of insulin resistance with moderately elevated insulin and glucose levels, and this is due to the lipolytic effects of growth hormone, and that should be monitored. This is another meta-analysis focusing on aerobic exercise capacity, traditionally bicycle ergometry, where in placebo-controlled trials you see an almost 10% increase in aerobic exercise capacity. As mentioned or indicated previously, you also see an increase in muscle volume, and this is roughly a 10% increase based on this meta-analysis. This many years ago led to someone coined the phrase the growth hormone deficiency syndrome in adults, and to the right you see several of the features which are listed. I haven't gone over all the features related to growth hormone deficiency in adults. No single symptom or sign is pathognomonic. One thing that is extremely important is that it has to start with a clinical context. All the placebo-controlled data that we have are based on patients with a very robust history of pituitary pathology, either adult onset growth hormone deficiency, which has been reconfirmed in adulthood, or patients with pronounced hypopituitarism after, for instance, pituitary surgery. So this is very important. This also translated into the formation of the Growth Hormone Research Society, and a lot of consensus meetings and reports have been issued over the years. This is the first one from 1998, focusing on the diagnosis and treatment of adult growth hormone deficiency. And these are just two other examples for more recent consensus papers on the diagnosis and treatment of growth hormone deficiency in childhood and adolescence, or you would call it the transition phase between childhood and adulthood, and also a new consensus study regarding adult growth hormone deficiency. I'd like to mention briefly, before I leave the word to Kevin, a recent study where we looked at the current practice of diagnosing growth hormone deficiency. And to this end, we used the Delphi method, where we asked a panel of experts a lot of questions or statements that they have to address or score. It's called the Delphi method, and it has been used quite successfully for these purposes by a lot of scientific communities. You are asked some statements that you can score on a Likert scale, and then you have iterative stages so that you are able to see what the panel has scored, and then you are able to score again. And the overall idea is that this should translate into perhaps increased consensus. For this particular Delphi survey, we asked both pediatric endocrinologists and adult endocrinologists on the diagnostic praxis regarding childhood patients and adult patients. I will focus only on the adult patient and the adult panel response to this. So we convened 25 adult endocrinologists from at least 4 different continents with expertise in the field, and they scored 32 statements related to the diagnosis of growth hormone deficiency: whom to test, when to test, how to test, and how to interpret test results. And we used a Likert type scale, And consensus was defined as 80% or more of panelists rating their agreement as either above 5, which means full agreement with the statement, or below 3, which means more or less full disagreement with a statement. Overall, the adult endocrinologists achieved a high degree of rate of consensus regarding all the domains, both how to interpret test results, how to test, when to test, and whom to test. I have summarized some of the highlights from this survey. There was consensus to consider testing patients with isolated childhood onset growth hormone deficiency. You have to test these patients before you consider to resume growth hormone replacement therapy in adulthood. You should test adult patients with pituitary or hypothalamic tumors, or offer the test at least. You should consider to test patients with one or more documented pituitary deficiencies. In general, one growth hormone stimulation test is sufficient if the clinical context is appropriate. The number of secretagogues that are considered useful include the insulin tolerance test, the methylmoralin that Kevin will discuss in more details, and the growth hormone releasing hormone plus arginine test, which Kevin will also address. Regarding consensus not to do something, you should not test unless you have controlled the other endocrine axes. You do not need to test with this growth hormone stimulation test if you have a clinical context with panhypopituitarism and a low IGF-1, because the likelihood of growth hormone deficiency is extremely high. You should not test an adult patient if the patient do not wish to receive growth hormone replacement. You should not test if growth hormone replacement is contraindicated, for instance, in the presence of cancer diseases. And clonidine, dopa, arginine, and exercise are not considered good secretagogues for a growth hormone stimulation test. So in summary, growth hormone replacement in adult hypopituitarism has stood the test of time as beneficial and safe, should only be considered in an appropriate clinical context, and requires a growth hormone stimulation test unless the patient is panhypopituitary. Thank you for your attention.
Thank you, Jens Otto, for your excellent presentation, and it's my honor and pleasure to introduce the next speaker, which is Kevin Yuang. He's a medical director of Barrow Pituitary Center and professor of medicine at the University of Arizona College of Medicine in Phoenix, Arizona, USA. Kevin.
Thank you.
Let's see whether you can share your screen.
Can you see my slides now?
Yeah, perfect. Thank you.
Okay. Thank you for the organizing committee for kindly inviting me. So my task today is to talk about the current, which is the use of growth hormone secretagogues. These are my disclosures. And the bottom line of understanding growth hormone stimulation tests is that it is an important aspect when it comes to confirming the diagnosis of growth hormone deficiency in adults. And the concept is twofold. One is to use a pharmacological agent that is strong enough to enhance or stimulate pituitary growth hormone secretion. And two, whilst that is happening, we measure growth hormone by time blood sampling at a specific time point in order to capture the highest growth hormone level detectable in order to make that diagnosis. And as Jens mentioned earlier in his talk, these are the 4 recommended tests recommended for testing in adults with possible diagnosis of growth hormone deficiency. And indeed, the three core principles of growth hormone stimulation testing firstly includes the fact that if you find that there is a subnormal rise, in other words, the peak growth hormone level does not achieve a specific cut point, by definition, that is growth hormone deficient, at least based on that testing by using a specific growth hormone secretagogue. The second core principle is that for different types of tests requires different growth hormone cut points, and the reason being is that they have different potencies of these growth hormone secretagogues in its ability to enhance growth hormones production. And also not forgetting that many of these growth hormone deficient or potential growth hormone deficient adults have underlying obesity, and therefore the impact of obesity and BMI can have an impact in reducing the ability to stimulate growth hormone secretion. But not forgetting the fact that each stimulation test has its own pros and cons. Some are more difficult to conduct in an office setting than others, and indeed some of these growth hormone secretagogues are not available in some countries. So we start off with the ITT, insulin tolerance test. I'm not going to spend a lot of time on this, but just to mention a few key points, that it is still the gold standard reference test that we use to confirm the diagnosis of growth hormone deficiency, and historically it's been used as the gold standard test. But as you can see here, there are several contraindications that prohibit its use in wider patient populations. It's very uncomfortable because it has to induce hypoglycemia and therefore requires very close medical supervision, which is the major inhibitor or the obstacle in allowing this test to be used in a wider nature in an office setting. And again, even with the strong stimulus of insulin, you can see in the presence of obesity, it can also suppress growth hormone secretion, as you can see in this figure here, where the light blue line represents patients who have obese individuals before, and then when you see that after they have had a procedure or medications where they are able to sustain their weight loss, you can see that the growth hormone response to the ITT increases substantially compared to before when they were still obese. And indeed, in some studies, this was a recent publication that because of that, although the current recommendations by the Endo Society and the American Association of Clinical Endocrinologists recommend the 3 to 5 micrograms per liter cut point as a current cut point to diagnose growth hormone deficiency, it's not surprising perhaps that we may need to even consider BMI dependent cut points, as you can see here in this study, where lean patients, the cut point could be used and a lower cut point of 3.5 micrograms per liter or less versus a lower cut point of 1.3 for overweight and obese individuals. Glucagon stimulation test is the more commonly used test, certainly here in the US. It's an alternative test, but it's markedly weaker than insulin. And again, you can see the contraindications where you cannot use it in certain types of patients. It has its own adverse events, nausea, vomiting being quite prevalent in these patients, and it's certainly not very conducive to perform in an office setting. It typically takes a long time, 3-4 hours, if not longer in some patients. And in some patients, especially the elderly, it can be quite unpleasant because of nausea and vomiting. And again, BMI specific cut points are needed, and there's also inadequate data in patients with diabetes and traumatic brain injury. In this study by Laura Dichtel, about 11 years ago, they showed that the accepted BMI, the accepted growth hormone cut point for glucagon stimulation test of 3 micrograms per liter may not be applicable if we have overweight obese patients. And here you can see here on the left side the ROC curve of a growth hormone peak of almost 1 microgram per liter gives you quite a nice sensitivity and specificity indicating that the lower growth hormone cut point is or should be considered in patients who are overweight or obese when interpreting these results. Likewise, for the growth hormone releasing hormone arginine test, again, a well-accepted alternative and indeed much easier to perform and safer than the insulin tolerance test. But again, there are contraindications and certainly some, but I would say milder adverse events, flushing being one of them and most prominent. But importantly, in patients with hypothalamic growth hormone deficiency, because of the mechanism of the action, it can also promote false negative results. And indeed, the BMI dependent cut points have been proposed by several professional societies, 11, 8, and 4, depending on the BMI of the patient. But in fact, there's another study by Gasco et al. From Italy, which again, they went back and looked at their cohort and found that perhaps even low cut points may need to be considered to increase the accuracy and reliability of the tests. And you can see here for obese patients that a lower cut point of 2.8 may need to be considered in these patients as well. Which brings me to mesymorelin or grivalin, which is, I've labeled it as the relatively new kid on the block in growth hormone testing. And why do I say that? Because you can see here in the history of key milestones, mesymorelin is indeed not that new. It's actually was synthesized first almost 26 years ago in Montpellier. And in fact, it was actually approved by the FDA in 2017 and by the EMA in 2019. And it was not only until a couple of years ago where Pharmanovia entered an exclusive agreement with Aeternus Zentaris, who was originally where the drug was manufactured, that they got the rights to supply this agent. And in fact, in the US, we've been using it for since the approval in 2017 for about 2 or 3 years before COVID, until COVID came. And then roughly in May 2023, we were not able to use it anymore because the sales of mesymorelin was discontinued. And currently, I'm told that Aeternus Zentaris is still searching for a new licensed partner to enable its distribution in the US. So I've used it for a couple of years, for 2 or 3 years, and until now, then I've not been able to do it now because it's no longer available. So you can see here it's extremely helpful in terms of meeting the unmet needs for adult growth hormone deficiency testing. It's orally administered, 3 to 4 blood draws, so much fewer blood draws than ITT. It has minimal contraindications, is generally well tolerated and safe, and only requires 90 minutes to be performed. And so these are all very positive attributes. In an earlier study, this group looked at mesymorelin and found that the dose of between 0.5 to 1.0 milligram per kilogram was effective in stimulating growth hormone secretion, and they were both similar in terms of their growth hormone Cmax, and mesymorelin has a half-life of roughly 3.5 hours. So how do you conduct the test? Well, firstly, you weigh the patient, and you can see here mesymorelin comes in pouches or sachets. So depending on the weight, if the patient is 120 kilos or less, you use 1 pouch. If they are more than 120 kilos, you use 2 pouches. Again, that's because the dose is weight-based. And 1 pouch, you then have 120 mils of water to be dissolved in, and obviously 2 pouches, you double the volume. You make sure you stir it gently for at least 2 to 3 minutes, and from then you calculate the volume for that respective weight. So for example, if the patient is 70 kilos, they will then require 17 mLs of reconstituted mesymorelin. So that's actually quite easy to calculate. And if it's 70 mLs, then you use a syringe to draw the volume out, and then you transfer it to a cup or a drinking glass. And very important, you have to make sure you watch the patient drink the entire volume of the solution within 30 seconds. And then after they've completed the drinking, then you start the clock, and then obviously you then draw the samples. I believe in Europe, you only require 45, 60, and 90 minutes blood draws for growth hormone determination. Messimorelin was actually previously studied, and it was compared originally to the GHRH arginine test. Here you can see the comparison. On the left side is the ROC curves with the ROC area under the curve of 0.923, so pretty high ROC area under the curve. 4.5 cut point gave you quite a high 90% sensitivity, but a somewhat lower specificity of 79%, whereas a 2.7 cut point gave you a slightly lower sensitivity and a very high 92% specificity. And indeed, the peak growth hormone levels correlated very well between these two tests of mesomorelin and GHRH arginine, even with those patients on the with hypothalamic growth hormone deficiency in the circles, as you can see in this figure here. Now, it was also compared with the ITT, and this was a study that we published about 6-7 years ago now, where we compared patients with from three categories: high risk, intermediate risk, and low risk growth hormone deficiency. High risk meaning those patients with severe pan-hypopit, and you can see here, as you would expect, very minimal stimulation of both tests. Intermediate risk would be patients with 1 or 2 pituitary hormone deficiencies and a low IGF-1. And you can see mesomorelin was comparable in terms of the growth hormone levels it stimulated compared to the ITT. And low-risk patients would be those who did not have any other pituitary hormone deficiency, or maybe one, or maybe with a history of distant traumatic brain injury. And then obviously we had the controls to compare with. And what you can see also is that there seems to be a greater potency of mesomorelin in stimulating growth hormone compared to insulin, as you can see in the blue bars, where it's slightly higher with mesomorelin than ITT. It has very good sensitivity, 87%, with a very high specificity of 96%, when the cut point of 2.8 was used compared to the ITT cut point of 5.1. So, and it's also highly reproducible with a very good safety profile. And you can see here, mesomorelin is very easy to use. You only need to do it once, and the results are highly reproducible compared to the ITT, where sometimes you may need to repeat the ITT if adequate hypoglycemia is not achieved. This is a table or figure that was slightly adapted. You can see here again the comparison of specificity and sensitivity of mesomorelin in the blue line to the ITT in the orange line. And what you can see here, even as high as a cut point of 5.1, the specificity of both tests, especially with the mesomorelin, was maintained. And if you see on the cut point of 5.1, the sensitivity was also above 90% with mesomorelin. So actually a cut point of 5.1 was actually a pretty good cut point. It also can also increase the sensitivity while maintaining specificity of the test. And during these studies, you can see that the main adverse events reported was dysgeusia, which is basically a very sort of a funny taste or a sour taste in the mouth that the patients reported. But this generally is not very unpleasant. Patients generally tolerate it, and it goes away within a few hours. Dizziness, fatigue, headaches, nausea, and hunger are the other tests that have been reported in these studies. We also looked at different characteristics of patients. So in this study, we looked at the effects of BMI and gender and age, and you can see here on the right hand side that when adjusted for age, BMI, and sex, the ROC area under the curve was actually still pretty high, above 0.9, suggesting that perhaps Messi-Morellin test is really not clinically affected by age, BMI, or sex. Now, importantly, the BMI in these patients were only up to 37%, so we cannot say what happens if the patient has a BMI of, say, 40 kilograms per meter squared. So practical tips when conducting the tests. First and foremost, if you are suspicious that the patient has hypothalamic disease, I guess you can still consider using the test, and if the test is negative, it's probably unlikely the patient has the disease, but if it's a positive result, then you may want to consider using another growth hormone stimulation test to validate the result. What about patients nowadays? You've probably seen patients who have undergone bypass surgery or for some reason gastric delay. So if they have diabetes with gastroparesis, you have to make sure you check and ensure that if they have this disease, it is possible it could affect the GI absorption of Messi-Morellin. Messi-Morellin also is known to cause have drug-to-drug interactions, can interfere with QT, causing potential QT prolongation. There's also medication list, so very important you check the patient's medication list before they start this test, especially if they're GLP-1 agonist. They may then need to consider adding another extra 120-150 minute sampling because of the fact that GLP-1s can reduce gastric emptying to a certain extent. And if they have a certain drug like SSRI, you may want to discuss with the prescribing provider, like the psychiatrist, to see if he is able or he or she is able to switch to an alternative drug or even stopping it temporarily while you're performing the test. And importantly, you have to observe the patient physically drink the drink over 30 seconds. May be difficult, I'm told. I've had a patient where there was some swallowing issues because he had previous neck radiation, so it may be difficult for some patients, and in this case, this test may not be a good test for that patient. So I've been asked also that what do you do if patients have long-acting GLP-1s who are going to undergo these tests? These are a couple of papers that were recently published where there was some recommendation of when to stop the GLP-1s before GI endoscopy or general anesthesia. But the bottom line is I don't think there's still good enough data to support routine cessation of GLP-1s and tirzepatide. So I think if you have a patient like that, I would suggest that you would either, if you're able to stop it, great, but if not, I think there's still not enough data to suggest routine stopping of these medications before testing for these patients. So here's the summary of Messi-Morellin, the only FDA and EMA approved growth hormone stimulation test for adults with for growth hormone deficiency. There's a lot more pros on the left-hand side than cons. Certainly in Europe, I'm told that the cost is actually not that high, roughly about 300 euros, as opposed to $4,500 in the US per package. So that's pretty expensive, and probably that's another reason I suspect why it's become unavailable. For patients with high likelihood of growth hormone deficiency, such as those with 2 or 3 pituitary hormone deficiencies, one can consider using the higher growth hormone cut point of 5.1. But bear in mind, there's no data for patients with a BMI above 37 and those with who are aged above 66. And it is my experience that it's generally the preferred test by clinicians, staff, and patients. With that, I thank you for your attention.
Well, thank you, Kevin, for this great overview of growth hormone stimulation tests and challenges, evidence, things that we might want to know when we have more experience. I would like to give the floor to Sharon Griseno now before we have time for Q&A to all speakers. So Sharon Griseno is a nurse consultant from Birmingham. He's lead nurse of the endocrinology and metabolism department, and involved in a lot of European European Society of Endocrinology to promote the nurse specialty within the endocrinology. So we are really excited that you're here, and we would like to hear your thoughts of growth hormone stimulations in practice.
Thank you very much, and thanks for the organizing committee for the invitation. I hope you can hear me okay.
Yes, I can. Thank you.
Excellent, thank you. So I think from the first two speaker, they presented already the clinical background regarding the use of different growth hormone stimulation tests, and my presentation will really focus on how we use this test in clinical practice from the perspective of the practitioner who doing this test in terms of the resources required. We also looked at how this test is experienced in real life by patients by looking at the different side effects that are experienced by patients undergoing this test, as well as the resources, including both the human resources and the material resources required in performing this test. So these are my disclosures. Just to begin, really, I give you a context. In the UK, we're slightly different in terms of when we can prescribe growth hormone treatment to patients with growth hormone deficiency. We have to abide with the NICE regulations, and the patient would need to meet 3 criteria before we can even prescribe this treatment. So the first is that the patient should at least be deficient in at least one pituitary hormone, and they're being adequately replaced in that hormone. The second, which is unique in the UK, is this patient should have a perceived impairment in the quality of life as assessed by the AGDA questionnaire, the quality of life AGDA questionnaire, and they should be scoring at least 11 points or higher on that questionnaire. And then the third is we need to prove that they're growth hormone deficient using one of these growth hormone stimulation tests. And as I mentioned earlier, criteria number 2 is quite unique in the UK. Now, the first two presenters already mentioned the different tests available, and over the years, there are other tests that's been used in practice, but in the UK, we've been concentrating mainly in using the ITT, the glucagon stimulation test, and the GHRH and arginine stimulation test. However, in the last 3 to 4 years, as you know, with the unavailability of GHRH, and also in the last 3 years, the unavailability of arginine, we are then limited to using ITT, glucagon, and most recently in 2023 with the approval of mesimorelin tests. Now, so I want to concentrate really our experience in Birmingham. We're a tertiary endocrine referral center, and I looked at the number of growth hormone stimulation tests that we've done over a 12-month period before the pandemic, from 1st of January 2019 to 31st of December 2019, and we did around 23 growth hormone stimulation tests. And we're mainly using, during that time before the pandemic, mainly ITT and glucagon stimulation tests. And there is almost an equal split on how many ITT and glucagon we were actually using. So as presented earlier already, the contraindications for ITT, as you know, are quite a long list, including patients who are quite elderly, those with cardiovascular disease, those with history of epilepsy or seizure, and those with untreated hypoadrenalism or hypothyroidism. For glucagon stimulation tests, we know the contraindications such as pheochromocytoma, those with glycogen storage disease, and severe cortisol deficiency. For both tests, patients are not advised to drive after the test. And in terms of the adverse effects, as presented earlier, there are quite significant adverse effects on both of these tests. But how does this translate into practice? So of the 12 patients who had ITT in 2019 in our center, you can see that all of them had adverse effects, which is good because that's what we want to see. We want to see that patients are stimulated using ITT, and that we induce that stress event in patients, and that in itself is a measure that the ITT is working and that we're stimulating, hopefully, growth hormone release. So this is not unusual. This is expected and what we really want to see. But from the person's perspective, of course, this is not quite pleasant for patient to have these adverse events. The most common adverse effects of ITT that we've seen is the dizziness, followed by feeling generally unwell, feeling clammy and cold. And we had 3 patients who ended up admitted in the hospital longer than required, longer than 4 hours for ITT. And 2 of these patients had to be admitted overnight because they became unwell after the test. And the other one of these 3 patients had to stay for around until 6 o'clock in the evening until the patient was stabilized. Compared to glucagon stimulation tests, 5 out of the 11 who undergone glucagon stimulation tests had adverse events, and the most common is the headache and nausea, and we only had 1 patient during that time who developed delayed hypoglycemia. So we're going to look at the resources. As I mentioned earlier, ITT is resource-intensive test. Majority of the center in the UK would require the presence of a medical practitioner all throughout that test. But again, that varies depending on the center. For example, in Birmingham, most of our only senior specialist nurses with prescribing right can perform this test. So we don't require the medical practitioner throughout the test. The medical practitioner is only required at the beginning to confirm that the patient can indeed proceed with the test. And then the nurse prescriber supported by another nurse can perform the test throughout that procedure. But again, despite not having a medical practitioner throughout that test, you can see the resources required for ITT is far more greater compared to glucagon stimulation tests. In terms of the cost, if we're going to concentrate on the testing agent alone, insulin is very cheap, about €8, for example, just for the human uptrapid alone. And glucagon is slightly more expensive, around €75, for example, for 1 pre-filled syringe, and some patients might require 2 syringes, around €150 for that. But remember that the cost of this test is not based on the testing agent alone. We have to take into consideration, of course, the cost where the test is performed, all the resources that we're using, including the practitioners involved in doing that test. So we're going to look at the time required to do this test, around 3.5 hours for ITT and around 4 hours for glucagon stimulation tests. And we look at the time where required to be able to do that test on each of those individual patients, the 12 patients who had undergone ITT in 2019. And you can see it varies with the average of around 199 minutes, but the range is anything between 189 to 320 minutes. The longest is 320 minutes for one of the patients. For glucagon simulation tests, it's fairly consistent, but you can see the average is far longer than ITT, is around 261 minutes, with a range of between 242 to 310 minutes, which is around more than 5 hours. Again, we have also need to look at the waiting list. Again, if the patient requires this test, we cannot just perform straight this test because we deal with other treatments and other tests within our endocrine departments. So currently our waiting list for ITT is around 6 to 8 weeks because we need to make sure that we have a nurse prescriber being available to do that test. And for glucagon simulating test, it's a lot longer. It's around 8 to 10 weeks because it requires 4 hours. So we need to find a 4-hour continuous slot in our testing unit to be able to accommodate the patients. So we're going to take into consideration all these factors, the resources required for doing ITT compared to glucagon simulation tests, the time required to do that test, including where we should be able to do this test. Both of these require patients to be monitored quite closely, particularly ITT. So as I mentioned by the first speaker, we can't just do this in an outpatient department. It has to be in a setting where cardiac monitoring is available. And the cost, for example, in Birmingham of performing ITT is around €750 or £700, and performing glucagon simulation tests is around €500 or 450 British pounds. So ITT is considerably more expensive compared to glucagon stimulation tests. So Just to summarize really, and this has already been covered, so I'm not going to dwell into this one in details in the interest of time. ITT in general is safe provided it is performed by experienced practitioner. However, we know it is not well tolerated by patients. Majority of the patient, or almost all patients, will have side effects, which is expected in this particular test. And both tests are not quick to perform. They're time-consuming tests. Professor Yuen already mentioned about masimorelin, which is an oral agent, which is quite easy to perform. And this was approved, particularly in our hospital, approved in the UK in 2022, and in our hospital was approved in February 2023. So what I'm going to be presenting to you is a patient experience in undergoing masimorelin test, and let's compare that to the ITT that we did in 2019. I cannot compare this to you directly because no two patients will undergo this two growth hormone stimulation tests. So I can only compare the experience of patients who have undergone masimorelin tests since it was approved from March 2023 to February 2024. So during the 12-month period, we then switched to masimorelin as a first testing agent of choice for growth hormone deficiency, and we've been using during that time only masimorelin and glucagon stimulation tests. ITT is still available, but there was no patient who we deemed appropriate for ITT. So we can compare these 12 patients who've undergone masimorelin to those who've undergone ITT in 2019. Contraindication of masimorelin are fairly limited, so only those patients who are allergic to the active substance of masimorelin. Adverse events, as mentioned by Professor Yuen, that unusual taste, nausea, headaches, and fatigue. And in practice, how many patients actually experience adverse events following masimorelin test? Only 1 out of those 12. And that was a patient who experienced dizziness, which was short-lived for around a few minutes. And the patient was able to go home shortly after that test. And again, if you're going to compare that to the experience of patient at ITT, where all of them had adverse events, you can see masimorelin is well tolerated by patients. Resources is not as extensive as ITT. We don't need a medical practitioner, particularly in our center where all our senior specialist nurses are prescriber. They can perform that test. We don't need a close monitoring equipment, a cardiac monitor to be able to perform this test. The challenge of testing agent, there are still several centers in the UK who are not able to do this test because most centers are just looking at the cost of the testing agent, and they're thinking that it will be far more expensive if they perform a masimorelin test, not taking into account the cost of performing the whole test itself. So masimorelin is around 320 euros or 300 British pounds in the UK. Compared, of course, to the testing agent used in ITT, which is only insulin, which is around 8 euros or £7.50. Duration of the test is only around 2 hours for masimorelin test, and you can see as compared to ITT, the average is just over 2 hours for masimorelin test, with a range of between 100 to 165. And looking at the data, really, the reason why some patients had to stay a bit longer than the 2 hours is some patients are quite difficult to cannulate, and you had to spend quite longer time to be able to establish a cannula for this patient for blood sampling. And because this test only requires 2 hours, so we can easily find slots in our testing units for a 2-hour period. So patients referred for ITT only had to wait for around 2 to 4 weeks before they're given an appointment. So we're going to look at the resources required for masimorelin test compared to ITT. So the cost of actually performing ITT, including the testing agent, is around 450 euros or 420 British pounds, compared, which is still far more expensive, the ITT, which is around 750 euros or 700 pounds. So there's really a place for masimorelin if we're going to take the whole context of performing the test rather than just comparing the testing agent, the cost of the testing agent, because the cost should take into consideration the whole test itself. So if we're going to look at how we're going to address really the challenge of offering masimorelin to patients, we need to look at really the patient's experience and the safety profile of both tests. Masimorelin is well tolerated by patients. You can see based on experience, only 1 patient had side effects, which is very, very minor side effects. And when costing it and trying to convince your organization to have masimorelin in your organization approved in your formulary is We need to look at the whole cost of the test itself, not just the testing agents. And look at how you're going to address the waiting list, because this test requires short period of time to perform the test, meaning you'll be able to accommodate more patients compared to sticking with insulin tolerance test or glucagon stimulation test. And to summarize again, as you can see and compared in here, ITT is still a gold standard test. It is still safe. However, there are challenges both on the patient side and in performing this test, considering the complexity of performing this test. We have a new agent, which is masimorelin, which is well tolerated, which is very simple to perform. Yes, there are challenges in terms of the cost, but we need to take into consideration the cost of performing the whole test rather than just the cost of the testing agent. Thank you very much.
Thank you, Shervin, for this excellent presentation. Very enlightening. So we have a couple of questions in the question box, but I just want to start with one general question, and that's we always consider the testing of adult growth hormone deficiency being a hurdle for treating adult growth hormone deficiency. Now we have something simple which we have had some experience of. So my question may be to put to you, all three of you, whether a simplified test and a more reliable test will increase the number of patients being treated with growth hormone. Who would like to start?
Well, I think I'll start first. Well, I think as what Jens mentioned earlier, it's still, although we have a test that is, I guess, easier to use, and I guess it still doesn't change the fact that we still have to test patients in the right context. And right context meaning with a history of pituitary disease and surgery and radiation. So initially when masimorelin came out, I was a little apprehensive, thinking, oh, is this going to encourage more testing? But it has to be tested in the right clinical setting. So, I mean, hopefully that will be the same, meaning the appropriate patients should still be selected for testing, not simply because the test is being made more amenable and available.
And Shervin, you looked at your data, so you're not testing more patients with masimorelin than you did before. So
I think the number of patients that we're referring for tests stays the same, because I think we are quite proactive. However, I get your point. There are several centers in the UK wherein they're not offering any testing at all, considering, for example, that they have a huge cohort of patients, hypopit patients. It's primarily because of the restrictions in terms of expertise in doing ITT and also restriction in doing the long test GST. And I think there's room for those centers, because I don't believe that if you have hypopit patients, that you should not be offering growth hormone, because, as you said, if they are deficient at least 3 hormones with low IGF-1, they are likely growth hormone deficient, but not proactively assessing and offering those patient treatment, I think is not fair for those patients.
Jens Otto, can you comment on that?
Well, yes, we have used masimorelin for 2 or 3 years and replaced it entirely with the ITT. And the number of tests that we perform has not increased. In our particular center, I think our awareness is relatively high. But I take the point from Gudmundur that it is likely to perhaps increase the number of tests in the future, since it is much more convenient, so to speak.
Shall we take we have 2 questions in the text or the question box, and that's maybe mainly for you, Jens Otto. So what is the target IGF-1 range for the best metabolic outcome? and how often do you measure IGF-1 during dose titration? So
according to the guidelines, we should strive to maintain IGF-1 within the upper normal range of normal, and it's not, and that's mainly a safety concern, and I also fully agree with that. It doesn't necessarily reflect the overall response to treatment, but we should avoid over treatment. So IGF-1 below the upper normal range. In terms of how often we measure it, at our place we measure it roughly 3 months after starting treatment, and to check if we need to increase or decrease the dose slightly, and then on an annual basis, because as we all know, the dose requirement decline as a function of chronological age. But it's really quite easy to monitor.
Do you prefer morning IGF-1, or doesn't it matter?
Whatever suits the patient. And
yeah.
Can we have one? Yeah, we maybe
yes, please.
Stop. But I'm just thinking about your experience with Massimorelin and the childhood onset cancer survivors who are many more hypothalamic reasons for their pituitary deficiency and growth hormone deficiency. So do you use Massimorelin for the retesting based on the available data that Kevin, you showed us, and the experience of the others?
Yeah, no, I guess it depends on the clinical context, right? I mean, if the patient already has more than 1 or 2 pituitary hormone deficiencies, the likelihood of deficiency is quite high. Not only the surgery and radiation. So if they had good response to growth hormone treatment as a child, and now they are transitioning into an adult, I think I've used it on not that many times, but I've used it on once or twice. Again, it really, your clinical suspicion should drive your choice of testing, and also the way you interpret the results as well, which is what, as a doctor, one should be doing. So I think that kind of helps me in making that choice of which test to go for and how I should be interpreting the results according to the clinical context.
Shervin, any comments on your practice, because you have a big clinic on cancer survivors?
Yeah, I think it's the same. That's why we won't be able to just use Massimorelin as a single test on its own, isn't it? So, and even though we're no longer using ITT much, we still have the glucagon stimulation test as an alternative test for those group of patients. So, and as Professor Ewan said, that needs the type of test that is appropriate for that patient is assessed at that point of consultations, and take into consideration the patient's background and which test would be most suitable for that patient.
Right. Yeah. And some words about the cutoffs, Nienke.
Yeah. So I was not that experienced. We started with doing the Massimorelin test this year because growth hormone releasing hormone was out of stock, and well, the impression was that many of the tested patients are either really below one of these suggested cutoffs of 2.6 microgram per liter, and the others are easily above 5.1. So there was not an issue of this gray zone. And of course, sometimes you get a patient that is within the gray zone. And then, of course, if you look at the data, I think the 5.1, especially in lean persons, is probably the best cutoff. Do you agree with that, Kevin and Sherwin and Jens, Otto, or what are your thoughts about that?
I think, yeah, the cut point of 5.1 again was used because we originally, historically, we looked at that because when we were comparing that cut point with ITTs, simply because ITT also had a cut point of 5 or 5.1. So we kind of looked at that to see, using the ITT as the reference test to see how it performed. But again, I suspect that mesomorelin is a stronger growth hormone secretagogue to insulin, which we showed in one of my slides earlier. So you may find that doing the ITT, your growth hormone peak may not be as high as, say, the mesomorelin in a patient who has a lower likelihood of being growth hormone deficient. So so you take that into consideration as well when you're trying to interpret the result. Which is why as over the years, I've kind of adopted the attitude of using the test according to your clinical suspicion of how likely the patient is growth hormone deficient, and using a higher cut point for those patients who you suspect have more than 2 or 3 pituitary deficiencies.
I think from the clinical context, Professor Ewan, I think we've seen that really quite a lot in the last 12 months. We have quite a number of patients, as you said, who had a really high likelihood to be growth hormone deficient, and they passed the mesomorelin because we used the 2.8 cutoff as mandated by NICE to us. So,
Yeah.
and then what we've done is we're after looking at our data where, because we had around 8 patients already where they just barely passed the mesomorelin test, and that we knew that they're growth hormone deficient, so we've done an ITT and they all failed in the ITT. So I think we agree that we have to use a slightly higher cutoff for those group, by the virtue that mesomorelin is a more potent secretagogue alone. I think we should be using a slightly higher cutoff, but we have to change our national guidelines for us to be able to do that, because there's so much restriction in the UK in terms of those cutoffs.
Yeah. Yeah, so our ITT cutoff used to be more or less 2.6. So that's also interesting. It's of course very assay dependent.
Yeah.
But yeah, I think that this is very valuable data and information to make individualized decisions, and maybe well, we and others are in the process of making national protocols, and I think it's important that we have these data available for recommendations. Thank you so much. I don't think there are any other questions from the audience.
No.
So I think we can conclude this webinar. I would like to thank the audience for their attendance and their interest in following this webinar and their questions. I would like to thank the speakers for their valuable contribution. Thank you so much for being here today. And I would like to thank my co-moderator for this well, exciting topic. Thank you so much.
Thank you.
Bye-bye.
Bye.